Welcome back to the MedEdit podcast, your go-to source for evidence-based medical education.
And the only podcast where two board-certified physicians interview specialists on the topics you care about. Today, we have our favorite rheumatologist on the show, Dr. Taylor Warmoth. She must love being on our show because this is her third appearance, or maybe we just love her. But in honor of June being Scleroderma Awareness Month, we're going to break it all down, all things about scleroderma.
And after that, Dr. Warmoth is going to help us break down a very popular topic, the use of complementary and alternative medicine for inflammatory diseases. I feel like this is all over the internet, so I'm really excited for that one.
Yeah, it's a lot to cover, so let's get started. We are your hosts, Dr. Cari Sorrell
and Dr. Jessica Gray. Welcome to the MedEdit podcast. Toss endless online searching to the curb. Let us edit out the noise and bring you medicine without misinformation. Welcome to the MedEdit podcast.
In case you don't remember, Dr. Warmoth is our go-to rheumatologist to discuss all things musculoskeletal and autoimmune. If you've not listened to them yet, you need to go back and check out one of our very first episodes where she talks about lupus, and then a later episode where we tackled osteoporosis. Welcome back, Dr. Warmoth.
You guys keep calling me your favorite, and I keep reminding you that I'm the only.
Yeah, like
oh no, we know others. You are our favorite, and let's throw it out there. We do love to feature our female, physician leaders and female, medical providers. So you are our only female one that we also think is amazing. So we're super excited for that.
Well, thank you. Yeah, it was exciting to bring a little estrogen back to the world of medicine. My practice.
We're all a little low on it, so I'm sure we can use some.
So our first topic is not one of the most common diseases we see. So I feel like somebody sitting here listening is probably going to be like, wait, I'm going to skip this one. I don't know anything about this. But no, you should not. Do not skip this. It's very interesting. So scleroderma, roughly, affects about 300,000 Americans in some form. It is not the most common disorder that Dr. Warmoth actually sees either, but it's one that can affect every organ system you have. So we're just going to go ahead and break it down. Taylor, let's start by defining what is scleroderma.
So scleroderma is one of the harder diseases that I treat. It is more rare, but it is definitely something I see at least once a week in my clinic. This is an autoimmune disease that tends to cause what we call fibrosis, which is very similar to scarring. Unfortunately, this scarring occurs everywhere, and we don't see it happen in response to something. So like if a patient, falls and cuts their arm, they may get a scar on their arm, but this is scarring that is happening without an injury. So scarring starts under the skin. It can get into the lungs, the kidneys, the heart, the brain. It can really affect any organ you have.
That's really interesting.
Yeah.
That's a good way to put it too. I think that is the best description I've ever heard of that.
Yeah. So what are some causes or risk factors for scleroderma?
Man, I wish we knew.
I know, right? That'd be nice.
We see it more in women, but that's classic of basically any autoimmune disease that exists. Typically, it's going to occur sometime between their 30s and their 60s. And interestingly, usually we'll see this disease is more common in African Americans or Hispanics or Caucasian. This one is most commonly seen in members of the Choctaw Nation in Oklahoma.
Wow. That's good to know.
They think, obviously there's some kind of genetic link here. And the question is could there be some external trigger, something that sets this off? So when you see one area of the entire world that has this disease, that makes you think, okay, something's triggering this, but we haven't isolated
some exposure or something. Interesting.
Mm-hmm.
So scleroderma is one of those tough diseases because, as we mentioned before, it can literally affect every single organ system. So I know this list will be extensive, but what symptoms do you normally see when you see scleroderma?
Yeah. So there's two types of scleroderma. It kind of depends on which type you have. So there's more than two, but in the diffuse types of scleroderma that I see, or the systemic scleroderma, it can be described as either limited or diffuse. And I feel like people think, oh, limited, that must be less. It's not. It's really, they're not great names. But what it references is how much skin is involved. So in patients with limited scleroderma, they tend to have significant tightening of the skin from the elbow down and from the neck up. In diffuse scleroderma, it can affect the entire body. It can become so tight in the abdomen that you cannot sit down. Jessica, I was at your wedding. You wore that beautiful tight mermaid dress. And I remember watching you try and sit the first time and you thought, wait, I can't bend here. But that happens in patients with scleroderma. The skin gets so tight that they lose the ability to either straighten or bend their fingers. They just kind of lock into this almost claw. We also see a lot of organ involvement. The most common involved is lung. It's the most feared effect of scleroderma. A lot of patients will develop what we call pulmonary arterial hypertension, or a big fancy word for high blood pressure in the lungs. And then some patients can develop pulmonary fibrosis, or scarring of that lung tissue, thickening of that lung tissue. Those are the most common causes of death in scleroderma patients. We can also see something called renal crisis. This has become way more rare as we have gotten better control over blood pressure. And then we can see a lot of involvement with the gut. So in particular, well, I'm going to let Dr. Sorrell help me out here, but we see a lot of involvement of the gut in patients with scleroderma.
Yeah, absolutely. I know our specialties intersect in multiple places, but on this topic, it would be that what I see a lot of is trouble swallowing, or dysphagia, as we call it, and reflux as well, because again, muscles just are not contracting or coordinating correctly. And it's fairly often, and I've actually diagnosed a few people with scleroderma on esophageal manometry, which is a test done to look at the pressure and the movement at the esophagus, who didn't really have a lot of other symptoms, or because the other symptoms were fairly benign, that this was their most presenting symptom that they had. So I have diagnosed that a few times. And then of course reflux as well, because things are just not coordinating correctly. It's also very common.
Yeah, that's one of the first symptoms that patients start to notice, like something's wrong. Typically in patients, they'll either notice the first thing is real puffy fingers, or severe what we call Raynaud's, which is when the blood vessels in the fingers spasm down so tightly that they start to lose blood flow to the fingers. Now, lots of people get splotchy fingers when it's cold out. That's the body doing what it's supposed to do. We need to keep warm blood around warm organs, our heart, our kidneys, our brain. If a finger falls off because I get too cold, it's not the end of the world. And so our bodies will sacrifice our fingers to save our hearts, our kidneys, our brains. But in Raynaud's patients, this happens with no explanation. It can happen with no cold exposure. It can happen with stress, with caffeine intake, with certain medications. And it can become so severe they can actually start to lose the tips of their fingers. So that's one symptom. And then the second one that pops up is they're like, you know what, I've had really bad heartburn lately, or difficulty swallowing.
So say someone has these symptoms you're talking about, and some of them, they come to see you, or maybe their primary care doctor, they may start somewhere. But how do you end up saying that you have a high suspicion of something going on? How do you go about diagnosing these things? Because the internet's going to tell you just need to take their special blood test and then eat their special, nutrition regimen and vitamins and all those things. Tell us, like, how do we actually figure out what this is?
So this is still diagnosed clinically, right? I look at a patient and I can see the stiffening of the skin. They actually have scores where you can say, like, how thick does the skin? How much can you pull this up? We look at the skin itself. Do they develop these things called telangiectasias, which are little bitty blood vessels that appear under the skin? Do they have abnormal nodules? Then other symptoms, things like heartburn. Are they dealing with shortness of breath? Are they dealing with high blood pressure that's unexplained? And then we bring in the blood work. In rheumatology, I heard this again and again and again, but no blood test diagnoses any disease. It has to be a combination. How does the patient look, and how is their blood work? And so the important thing with scleroderma is there are about 5 or 6 different antibodies that we know of. And these antibodies kind of predict how the disease may behave, so to speak. We talk about diseases like they're enemies that we're fighting. And so we will call them, how is the disease going to behave? How does it present? And so knowing those antibodies is important because we know what symptoms to keep the closest eye out for.
Yeah. Interesting. And sadly, we know there's not a cure for scleroderma per se, but what are some of the treatment options that you will offer to your patients?
So for the most part, my patients are actually usually spared immunosuppression because the studies that we have done show unless their disease is severe, they don't seem to respond much to immunosuppression. If we do, we tend to use a medicine called Cellcept. There's one called cyclophosphamide. There are some newer drugs on the market that are kind of being experimented with. I've got a few patients trying those out, and so far I've seen really beautiful results. So I'm keeping my fingers crossed for those patients. But for the most part, treating scleroderma is band-aiding the symptoms. There are a few new drugs out for lung involvement, particularly that high blood pressure or the fibrosis of the lungs. But for the most part, if they're having bad heartburn, I send them to someone like Cari. And we see, do they need dilation of that esophagus? Do they need higher dose medications to help with heartburn? Do they need a lung transplant? Do they need oxygen at nighttime? And so that's the really unfortunate part of this disease is there is no cure. There doesn't seem to be a way to slow it down. We just band-aid the symptoms.
So you mentioned a little bit already about the drugs coming out. So what areas of research of these future treatments may we be able to look forward to in the future?
Yeah, absolutely. So the biggest area of research is probably still focusing on the lungs. We've actually had 2 new drugs come out within the last, I want to say 5 years because I feel like I haven't been doing this long, but looking back 10. But we've had 2 new drugs come on the market, and there are plenty more kind of following because with the lungs being the most common cause of death in these patients, that's where most of the focus is. We're also looking at some anti-fibrotic agents for the skin. And so while I don't think there is an actual study anywhere in the world being done with this, there is a new drug on the market for rheumatoid arthritis and psoriatic arthritis that we have given to 1 or 2 patients in combination with a dermatologist here in town. And we've seen really promising results. So I've actually reached out to that company and we're in the process of trying to get a clinical trial started there. The problem with diseases like scleroderma is as horrible as they are also very rare. And so it is hard to get large studies like I can with rheumatoid to prove that a drug works. And I mean, thank God for that. But it does mean if something comes on the market, we may only be studying it in 50 to 70 people.
Right.
Yeah, that makes sense. That is an aspect we don't always think about.
Yeah. Well, fascinating. Thank you very much for filling us in on all things scleroderma in honor of Scleroderma Awareness Month.
So during the next part of today's episode, we're going to tackle a topic that has been trending, I feel like, for the last several years, especially on social media. That is the use of complementary and alternative medicine for inflammatory diseases. Specifically, we're talking about things like Dr. Warmoth's most favorite things to talk about, rheumatoid arthritis, lupus, scleroderma, as we mentioned before, and other autoimmune disorders. We will talk about some herbal therapies, some mind-body therapies. Most importantly, we'll discuss if any of this actually works. We're talking about evidence to support this, that evidence-based medicine. This is important for physicians, healthcare providers to educate themselves on because, well, it's popular with patients. So we need to know what does work. And there are alternative therapies that do work, spoiler alert there. There's some things that do work, but there's so many that don't work and that their companies are perfectly happy to take your money for, right? The complementary and alternative medicine market is experiencing significant growth. We're talking about projections estimating it will reach 1.7 trillion by 2034. So I always like to point this out. We all hate big pharma, right? Big pharma this, big pharma that. Like they're all against this. They make things hard for us or, they may have all these things. But I will tell you, big pharma was one of the most regulated industries that exist. The amount of things it takes to get something through a clinical trial and testing and all of that to be done is extremely regulated. The complementary and alternative medicine market is unregulated, 100% unregulated. And the trillions of dollars that it is bringing in can be a problem. So we do need to look at this pretty carefully when we're having these discussions.
Dr. Warmoth, I know this first topic is something that has come up in my practice for use in inflammatory bowel disease, so I'm sure it has in yours as well. But I want to get your take on turmeric, or specifically the extract that's active in turmeric, which is curcumin.
Curcumin, yes. So turmeric actually has some really good data. We've done research for this in rheumatoid arthritis. They've done a little in lupus. They've done a lot in osteoarthritis. It's a good option for patients. It is. It has a very poor, what we call bioavailability, meaning our body doesn't convert it to the active forms well, which is why you see a lot of this curcumin over the counter instead of just turmeric. The thought behind this is the active form of the medication. And so maybe taking that will get you better results. Turmeric is a very good all-natural anti-inflammatory. It actually has been shown to work decreasing pain very significantly in a significant number of patients with osteoarthritis especially. It does seem to help in rheumatoid as well with pain. There's one really big caveat here. Pain does not necessarily equal inflammation. And so just because a rheumatoid patient is not having active pain does not mean active joint destruction is not occurring. I think I used a double negative there, but I hope you understand what
So
I'm
you're saying
that
you're not going to be able to
because
treat
you
the
don't hurt.
problem, right? Like it's not solving the problem. It's just maybe that
Exactly.
Band-Aid again.
Masking it. And yes, we're bringing inflammation down a little bit, but you have to understand how significant the inflammation is in autoimmune diseases. This is not something that you can take an Advil for and the problem is fixed. And so while turmeric is a fantastic kind of adjuvant medicine to help decrease pain or inflammation, or even help you avoid taking Tylenol, ibuprofen, and some additional medications, typically in the setting of things like rheumatoid arthritis, immunosuppressants are still necessary.
Yeah. And I think it's probably very similar to how I approach probiotics with inflammatory bowel disease patients. It's a great adjunct, or as the title suggests, complementary treatment, but it doesn't replace medical therapy, which is going to be the mainstay of decreasing that inflammation. And I do also think it's important to note that just because you sprinkle a little bit of turmeric on your chicken for dinner, probably not going to be high enough doses, right? Because doses, when I was reading about this, they have for some of these, it's like fairly high.
Turmeric is a high dose that's really necessary. So you need 400 to 600 milligrams 3 times a day.
Okay, so it's not like that
Do you know
one
how many
pill
of my
someone
patients
takes.
laugh in my face?
Yeah.
Yeah. When I tell someone we're going to take this pill 3 times a day, they're like, no, I'm not going to do that.
Yeah. So, I mean,
I don't blame them.
It's not just like I said, you can't just sprinkle it on some stuff and then be like, well, there's my anti-inflammatory diet done for the day. So that's why, right. Exactly. As we kind of talk about some of, like, we touched on what I would consider an herbal remedy. Some of the other ones that are touted pretty frequently are things like ginger, boswellia, or frankincense is, the term that I use, echinacea, or ashwagandha, which has also become very trendy lately. Do you have any thoughts on any of these other herbal therapies?
Okay, so the way that the World Health Organization defines CAM therapy, which is complementary and alternative medicine, again, I'm going to read it. I have my notes here. A broad set of healthcare practices that are not part of the country's own tradition and are not integrated into the dominant healthcare system. This is not quackery. This is not fraud, which is someone trying to sell you something they know doesn't work. But these things are not regulated and they are not widely studied. However, in my clinical practice, I will note that patients frequently mention that rubbing something like frankincense on a joint tends to decrease pain. The thought process behind this is that a lot of the things that are rubbed on joints, like glucosamine seems to do this a little bit, frankincense seems to do this, capsaicin, which is from peppers, they seem to decrease secretion of something called substance P. Substance P is at the very terminal ends of the nerves, the last strip of nerve system that you have there, and it seems to decrease pain and maybe a little bit of inflammation. The thing is the effects from these are incredibly temporary. 60 minutes of relief. And it's just, that's not enough relief to justify me running to my car 12 times a day during my work day to rub some stuff on my arm and then head back to work. in a pinch, they're great options, right? So I always joke with my patients, but I was flying to my brother's wedding, threw out my shoulder, loading in a suitcase. And I knew because it was open bar, I didn't want to take any Advil. So I slapped a capsaicin patch on my shoulder, and it worked throughout the rest of the day. I was able to be out on that dance floor making a scene. But again, it was an open bar. So, it helped my pain very significantly. But the second that patch came off, my pain was back.
I think that's a really good point. And then also, I think you're making a good point too about the mode of delivery, because I do think sometimes, we're talking about some of these things and people will just think everything you need to ingest and be in a pill to be effective, right? And so I've seen strange versions of things that, like you're talking about, you like a capsaicin. We know that's supposed to, it's made from peppers. It's, you put it on the skin. Well, there's other things that they're like, well, you make the similar idea of what it's made from, but they like, we made it in pill form, so you can just take it as a pill. Well, that doesn't seem to make sense, I feel like, for, the route of administration that you're talking about. And so not everything has to be pill form to be magically like effective.
Yeah. I love topical agents for my patients because let's say they do have scleroderma and their gut doesn't digest things. Or we learn about in med school, to bring back pharmacology, something called first pass metabolism, which means that your liver has to activate the medicine. Well, if your liver isn't in pristine condition, your meds may not work, or worse, they may hurt you.
Yep.
Even if they're all natural.
Yeah. And I think the only caveat, I think the only caveat for all natural, which I do agree, I think any of these things that can help people decrease the amount of oral pain medications they have to take, either prescribed or over the counter, is always a good thing. I just think in general, like you mentioned, it's not well regulated. So you do have to make sure you talk to your healthcare provider about these things. Even with ashwagandha, I've seen people's liver enzymes go up who take it for a very long period of time at very high doses. So they are not completely benign, which is why just because it's not a quote unquote medication means it can't hurt you. So you definitely are things that you want to make sure you talk about, because there can be some benefit as a complementary medication if taken appropriately in the right patient.
And drug-drug interactions are real too.
That's what I tell people. You have got to tell me everything. I tell them, bring a bag of all of your pills, because there are so many interactions. Most commonly, we see blood thinning effects with a lot of these guys. And so if you're, prone to bleeding already, and a lot of patients with connective tissue diseases are, that's really important to know.
The other CAM modalities that we want to discuss were what was termed more as like the mind-body therapies, such as yoga, meditation, acupuncture. Tell us more where you stand, what you've seen in the clinical studies, the research. What's behind there?
I love this kind of stuff. This stuff is so, so good for patients. I mean, what's the risk of exercise?
Right. I know, right?
So the thing is these forms of exercise are mind-based. So things like yoga, tai chi, meditation. And there have been some pretty extensive studies proving that these work for things like osteoarthritis pain, even fibromyalgia. There are really good studies showing that mind-body based exercises work. What I tell my female patients, because most of them are female, is if you remember when you were in labor and they tell you to focus on your breathing, do your hee-hee-hoos, I go, look, it's not an epidural, but you have to admit it helped a little bit. Sure. And, reducing that pain or changing your focus. The idea is that with significant enough meditation or understanding of your body and the way it truly moves, you were actually able to reduce your brain's signaling of pain. We have seen this in studies where they put people in an MRI, asked them to meditate, which is really hard to do in an MRI.
Yeah.
And then they inflicted pain. They use a hot rod, which they very nicely described a curling iron, but they burned these patients while they were in the MRI. And when they meditated versus when they didn't meditate, their pain differed by nearly 70%.
70%. That's
so
huge.
Meditation, 70. Meditation really seems to help reduce pain.
I love that.
So I highly recommend it.
Great. And I bet you're asked pretty frequently about some supplements that don't just include what we've listed above, but the omega-3 fatty acids, the glucosamine, the chondroitin, which I feel like I've seen every person over the age of 50 beyond.
Collagen supplements. Yeah.
Fill us in. Is it worth it or not?
I've asked you this.
Yeah.
Yeah, so big fan of omega-3s, but I think it's best to just get them through diet. So if you're, consuming any kind of food that's cooked in oil or uses oil, please use olive oil or an avocado oil. Those are really high in omega-3s and a great natural source. I love popcorn popped now in avocado
Me
oil.
too.
Mhm.
Me too.
That kind of thing, I'm a big pop.
So good. Lesser evil. I mean,
Oh my gosh,
we
they're
are
my
not
favorite.
sponsored, even though I would love to be, but
Yeah,
my
come call us.
favorite. So
Yeah, Act 2, call me anytime.
Yeah.
Warmoth, I'm a big fan. Anyway, so yes, omega-3s are great. Glucosamine has also been shown to maybe reduce the secretion of this substance P that's associated with pain, but it really only was shown to help 20 to 30% of people who tried it. So if you want to try it, it's relatively cheap, it's easy to take, but in an ideal world, do not give it more than 2 months. If it's not helping you within 2 months, it's just not meant for you.
That's a good number to give.
There are some thoughts that this could be, problematic in patients with shellfish allergies. So if you have a shellfish allergy, avoid it. Chondroitin is useless. Don't waste your money. Now, most of the time, glucosamine and chondroitin are together. If that's all you can find, that's fine. But there's just no studies supporting chondroitin.
Very good to know. Okay, so all right, cryotherapy, worth the hype to combat inflammation. Definitely tried it out like a couple of weeks ago and thought it was really entertaining to be in minus 146 degrees or whatever Fahrenheit. And I thought it was just crazy. But what does it do? Does it actually do anything? There's some people I know that are just like religious about it.
So what we know about cryotherapy right now is that it does seem to decrease pain sensation very significantly for about 1 hour. Well, this is definitely not something I don't think anybody would pay to do once an hour, but it does seem to decrease pain. In theory, it's also going to decrease inflammation. When we look at this in what we call in vitro studies, so not in real human bodies, this seems to reduce use or production of two chemicals in particular, TNF alpha and interleukin 6. Both of these were associated with inflammation. And in fact, two things that we target with medicines like Humira, Actimra in patients with rheumatoid arthritis. But if it's only reducing inflammation for an hour, it's
Right.
not something that theoretically would be something you could use for rheumatoid. Now, for pain, great option, but not something I would use to try and combat inflammation as the only source.
Yeah. Again, complementary, which I think is, I mean, you probably approach it very similar to I do as well, is that I always tell people, especially because I get asked a lot about this with inflammatory bowel disease, is that if I don't have evidence that it hurts you
Mhm.
and it's not going to bankrupt you, I'm fine trying it. I
Mhm.
can't tell you I have evidence that it's going to help, but let's try it. As long as I know it's not going to hurt you and you're not spending a ton of money doing it, then let's give it a try and we'll see if it helps you, because I just don't have the evidence.
Because I don't want to alienate any patients either. If I can help them best by giving them a little bit of our medicine and a lot of things that they think are helpful, if they truly feel that they're benefiting, then who am I to tell them, no, it's not, that's not helping you, don't take it. And so that's something that we need to be very open with our patients is I don't have great data, but it's worth trying.
Yeah, for sure. And lastly, of course, because we almost talk about this every episode, let's talk about diet.
Mm-hmm.
Okay, so the autoimmune diet on social media, I see it everywhere on TikTok, on Instagram. So if someone really wants to reduce inflammation by changing their diet, what are some diet changes that they can make that will actually help them?
So truly the best diet out there for inflammation is the Mediterranean style diet. Autoimmune diet is still a good diet, that AIP autoimmune protocol, but it's really, really strict. It's pretty expensive. It has a high fail rate. And so I prefer the Mediterranean, which I think is just a little more user friendly. This is going to be a diet that's hard to do in West Texas, truly, but it cuts out a lot of red meat and focuses more on pescatarian style eating. So lots of omegas from actual, ideally fresh caught fish, but any kind of fish. And then you can supplement with chicken and turkey as necessary. Again, they're cutting out almost all oils except for avocado oil and olive oil. They're cutting out refined and processed sugars in exchange for more natural sugars. And they always talk about with these things, two things: the more colorful your plate, the more healthy if it's natural coloring. And they talk about do the perimeter shopping at the grocery store. If you can avoid those main center aisles and instead shop in the perimeter where you have your basic vegetables, your wheat, your actual meats, your dairy, that kind of thing, that seems to be beneficial. Now, there are some patients who are very sensitive to gluten and maybe not actually celiac, but gluten sensitive. And so some patients will note that their arthritis flares after eating a lot of gluten. Some studies have shown that nightshade vegetables may increase inflammation in certain patients as well. So nightshades are things like eggplant, potatoes, my personal favorite, red bell peppers, and certain orange bell peppers, that kind of thing. Oh, and tomatoes.
Yeah, I was actually going to throw that out
I don't eat
there.
a lot of tomato anyway. But.
Yeah, because I have a nickel allergy, completely off topic here, and got an advertisement for low nickel tomato sauce. And I was like, what? Wait, is tomato sauce high nickel? And apparently because of the reaction it has with the can that it's normally in, it can have high concentrations of nickel in it.
Ooh, that's
I know.
interesting.
I literally, guys, do not quote me on this because I don't know if there's any evidence or research on it. It was
We'll have to
more
look it up.
of just, I got an email advertising low nickel tomato sauce. It was kind of like, wait, tomato sauce has nickel in it? So TBD, we'll look into this further, but just mentioning like foods and causing issues, that I thought that was very strange.
Wow.
That's fascinating.
Yeah.
So excellent information as always, Dr. Warmoth. Thank you for chatting with us once more. We really, really love having you on. It's always lots of fun.
It's always so fun to be here with you ladies.
And thanks everyone for tuning in. Don't forget to subscribe, follow us on Instagram and TikTok, and let us know what other topics you'd like us to cover. And we'll see you next time on the MedEdit podcast.
Thank you for listening to the MedEdit podcast. Please click the follow button to be notified when more episodes become available. For more information about this episode and to find out how you can reach Dr. Cari Sorrell and Dr. Jessica Gray, please visit today's show notes. Be sure to follow us on our socials, Facebook, Instagram, and TikTok to stay up to date on all things the MedEdit podcast. The information and content has been made available for informational and educational purposes only and does not constitute a physician-patient relationship. If you need medical advice or help, please contact your personal physician. The views and opinions of the guests do not necessarily reflect the views of Dr. Jessica Gray or Dr. Cari Sorrell. This podcast should not be considered an alternative to medical advice or diagnosis or confirmation of an illness or disease. Please seek help from your personal care practitioner. Thank you for listening and tune in next time.